And when Subhash called me and said, would I speak, I was so excited. And then I said, well, an interventional meeting is usually a show-off meeting for everyone. And he asked me to present medical management. So for point of reference, I was their first fellow when Manos and Subhash were first year attending. So I think I pissed them off 15 years ago, and they're going to make me talk about medical management of CLI. So disclosures are here. I do love to ski. So we've had a lot of talk about the way to develop multidisciplinary approach. And most of these, as you've seen, have been done from large health systems. So one of the two centers I work at is a community-based hospital, 420 licensed beds. And 4 or 5 years ago, 2 of our podiatrists, which have a dedicated practice, mainly towards DFUs, talked with me and said, look, we want a wound care center, but we don't want a wound care center like every place else in town, which is essentially designed to have patients undergo hyperbaric oxygen therapy. So we said, well, how can we in the community mimic what people do on a bigger scale? So we have 4 dedicated podiatrists, again, 2 which have a practice geared towards DFUs. We have an infectious disease doctor, a dermatologist, a plastic surgeon, a general surgeon, myself, a vascular surgeon that fits somewhere between the role of competitive and collaborative, and 2 HBO chambers. We meet monthly, discuss patients, and have again tried to mimic what bigger organizations have done. So my patient. Patient is 66 years of age. He has a history years ago of a prior right AKA. He has a known right common iliac and an external iliac occlusion, which was stented in the past. Diabetes, hypertension, CAD, hyperlipidemia, dietary noncompliance, heavy tobacco use, and we'll learn in a bit other smoking use. I was called from his assisted living facility where he was having severe left lower extremity pain and blistering. 6 months ago, he had presented with acute limb ischemia of that limb with Rutherford stage 4 symptoms. He was able to obtain a duplex prior to me knowing about him at his assisted living facility, which showed occlusion of his SFA and POP. Notably, 6 months ago when he came in, this guy's sick enough that when he was waiting his peripheral angio, he had an MI, underwent emergent PCI of his circumflex. So just painting the whole picture of not great protoplasm. So we decided, based on this, that similar to when I saw him last time, we would just go primary pedal. He had a good PT last time when we intervened. His length of disease was difficult to see what was below the knee, and we didn't know even if we went radial we could go, and upper over access wasn't done. As an interventional cardiologist, I've learned in the last couple of years that there's a marked benefit of having anesthesia in cases of CLI to keep the patient comfortable, to keep him asleep, to keep him from moving. So we got ultrasound guided access in the PT, placed a 4-5 glide cylinder sheath. And this is difficult to see, but here is his SFA, which was treated previously to some flow limiting dissection with superior stents. And you can see here below the knee, there's thrombotic occlusion. So this is where when we say we want to treat things medically that we think we had a complication. And in fact, we didn't have a complication. We actually dripped him overnight. We intubated him overnight, dripped him, and the case was successful. Most of the thrombosis cleaned up. This was prior to the DCB controversy, so we treated his stent occlusion with DCB after IVUS and had minimal POBA, and his leg and foot remained viable. So this should be a success. And most of these cases, when we see the patient the next day, they thank us, they love us, they're so happy. Unfortunately, this guy, all he really wanted to do is eat Doritos and weed, and he smoked weed, and he said, gosh, I didn't even want any of this done. I don't even care if I have a leg. I just need to transfer to smoke weed. So unbeknownst to me, in Colorado, in assisted living facilities, depending on how they are, since marijuana is legal, so is smoking marijuana. And he sat around with a group of guys all day, and that's all he did. So as I walked into his room the next day, waiting for complete happiness that he was happy, he signed out against medical advice. So we DC'd him home. We placed him on rivaroxaban. His limb, last he came into the office, which he stopped doing, was still viable, but his hemoglobin A1C was 14.5%. So he can still transfer himself to the wheelchair, doesn't need in getting assistance in whatever substance he needs. So we know this is why we're all dedicated to CLI. The rate of mortality rate in patients who undergo amputation is higher than most cancers we know. But there's this concept of shared decision making. And I don't think beforehand this patient would have said, no, don't do this. But a lot of these patients are very complicated. We're not just faced with the 50-some-year-old who's got a threatened limb, but some of the patients have a painful non-healing wound, not necessarily threatened, and are 90 and have platelet counts of 60,000. And this is the case where involving family, patients, having multidisciplinary conferences really helps us make the best informed decision, both for us and the patient. So in conclusion, revascularization is obviously a cornerstone in the therapy in patients with CLI. For myself, as a cardiologist, the continued expansion of this patient base in my practice has been one of the most rewarding things that's happened. But on rare occasions, even though patients have successful quote-unquote outcomes, it's not met with the same feeling of a rolling reward. But again, in conclusion, I don't necessarily wish I treated this patient medically. And thank you.